We begin the session, as Dr. Bansi had requested, one slide on history of diabetes, something related to the history. So we all remember 1921-22, and we remember Banting and Best as the discoverers of insulin. What very few people know is there is someone called James Collip, who was also associated in discovery of insulin along with Banting and Best. And during the same year in 1922, he did measure the potency of insulin by injecting it into rabbit, and found out the subsequent drop in blood sugars. And this later was explained by Harris in 1924, and hypoglycemia was discovered as one of the side effects of insulin therapy, and it was considered to be one of the complications of insulin treatment at that time. And later on in 1938, it was discovered that you correct hypoglycemia by subsequently giving glucose, and the symptoms of hypoglycemia were discovered later on at that time. So moving on, something is what we know as progress has been defined by somebody as a constant change or a need to improve, as well as to replace something which is best with something still better. I think when we think about insulin therapy, when we think about the history of insulin, we understand that this definition goes very well with it. It's a molecule which was discovered in 1921 in desperate situations. Basically, it's as a life-saving drug at that moment of time, and from that on, the journey of insulin has been unique. And today we have evolved into a molecule which is precise, which is definite, and which we are changing according to the needs of patients with diabetes. So my first, as we go ahead further, how has the diabetes management evolved, and has there been a corresponding evolution of insulin therapy? Dr. Marwa?
Good afternoon, everybody, and I also thank Dr. Bansi Sabu for his one more episode of diabetes and endocrinology and obesity in our country. I am also thankful to my dear colleague and friend, childhood friend, Dr. Tibrewal, and my colleagues from across India, Dr. Salini and Dr. Tejas, for making this event. And also great thanks to Novo. Now, as we know, the diabetes has increased enormously over centuries, and India has become the capital of diabetes, and number is increasing day by day, year by year. And as the problem increases, we have to find the solutions. The question is, yes. So we are all aware of the epidemiology that India is the capital of diabetes of the world, and in spite of all this awareness and also possibilities to treat diabetes, we still have 80% of patients whose diabetes is not under control. HbA1c is very, very high, much above the target, and in spite of all available tools to treat diabetes, we are still not using in the optimum way. Particularly the treatment which we can offer to our patient through insulin is delayed by almost a decade. And only 30% of patients are being managed with insulin. I think this number is even more than what we see in our day-to-day life or practice. It may be less than 10%. So anyway, there is a huge challenge, and they just said that there had been lots of discoveries which has happened around these years to conquer this challenge. Before 100 years or so, type 1 diabetes patients, they were not living more than 6 months. The longevity was only 6 months, and when Banting, he discovered insulin, and then it changed everything, and the longevity increased by almost 25 to 30 years. But then again it was found that this is not good enough. People clapped. Banting and Best awarded Nobel Prize, Banting and McLeod in fact. And then there was a question that, okay, we need insulin every 6 hours. This is not good enough. It is very cumbersome. So there was a discovery called NPH, invented protaminated insulin, and through which we can give insulin with a lesser frequency, twice a day or so. Again, he was awarded Nobel Prize. Then the question came, oh, these insulins are dirty insulins, animal insulin, and these are not good. They are giving lots of reactions and lipohypertrophy, dystrophy. There is shortage of insulin. Then biotechnology helped, and we could form more insulin through in a bulk quantity without any restriction through E. coli and other fungus. And again, there was a Nobel Prize to Hargoin Khurana and his team. Of course, it was not directly for insulin, but this discovery did help, and now at least there is no shortage of insulin worldwide. Then this was not good enough. Okay, we found out insulin, we found out human insulin, we find out insulin which is less immunogenic, but then there are problems. We get hypos and hyper. Patients have a very difficult life. So again the question came, oh, this is not good enough. We need to have something better. We need to have good which can control prandial hyperglycemia. So neuroinsulin analog came, aspart came. If we go by the name to understand easily, mixed-ard and then no mix. Then again, oh, this is not good. We must have something better. And we are having, no mixed and mixed-ard, they are controlling diabetes, but they are creating hypoglycemia, and hypoglycemia is very dangerous and detrimental, and it can create lots of problems. So again, the new discovery came, and that's called Tresiba, and with newer preparation called Razodec. So again, the benefits were to reduce hypoglycemia and at the same time controlling diabetes. So of course, the insulin has, if we see in 100 years, there has been lots of discoveries which have tried to overcome these challenges, and we have come to a stage where we are having better insulin and also with lesser chances of hypo and hyperglycemia. So can Salini, you can continue further?
Sure, sir. So obviously, sir talked about the journey of insulin discovery, and we've moved from conventional insulins to the animal insulins and then the newer analogs. So most important thing to understand is why do we need to evolve? I think when any new thing comes, generation 1 and then you evolve to gen 2, gen 3, gen 4, you've seen how technology evolves, how mobile phone evolves. So when we had the conventional insulins, of course, they were a saving grace. They were a boon to people who used to die without insulin. But then, of course, they had their own limitations. So I'll take you through a few limitations of the conventional insulins and what were the challenges that people faced. Like sir said, variable absorption. So that was very important, So when you need it, it's still not active, and when you don't need it, it is still on board, so you get delayed hypoglycemias and you get immediate post-meal hyperglycemias. Second very important thing, the fear of hypoglycemia, which can take your patient completely off insulin. One bad hypoglycemia and the patient stops taking insulin. So with conventional insulins, hypoglycemia was a major challenge. And then no flexibility at all. So, you have to time it at least 30 minutes or 60 minutes before a meal and so on and so forth. So that was a huge challenge, especially for people in today's times. When you want everything quick, you have 2-minute Maggi noodles. So you need an insulin just before the meal, or sometimes, I forgot to take my insulin. I've just finished a meal. I'm mid-meal. I can still take an insulin shot. So the kind of flexibility, this was something which was a huge challenge with conventional insulins, and of course they used to go in slow, very slow onset, and then very less predictable action. You don't know when it is going to be on board. Rigid dosing schedule, very, very important challenge that we faced when we were using conventional insulins. This is, I remember, our professors used to talk about using animal insulins. Then when we were training as students, we were using ectrapids and mixtards and isophane insulins, and now we're all playing around with all the designer insulins and all the newer molecules. So delayed action, more dose requirement because of the inconsistency in action, and these were a lot of challenges that we faced. So Dr. Tejas, with these limitations that we've had with conventional insulins, would you like to comment on how the co-formulation has improved glycemic control, safety outcomes, and how all these challenges seem to have been addressed with the newer co-formulation insulin that we have?
Thank you. Yes, Shalini has spoken about the shortcomings that the conventional insulins that we've been using for so long has. definitely variability in glycemic control, incomplete 24 hours basal coverage. Let us understand that the premix mixtures that we've been using till now primarily didn't have a longer 24-hour acting analog mixed with it. They were more or less what we've been using till now were NPH, which is an intermediate acting insulin, as well as it is usually mixed with a shorter acting one, which therefore it requires a suspension needs to be mixed. The patient has to roll the insulin well between the palms to mix the intermediate acting and the short acting together in order to have a proper effect. And this was also one of the problems, that patients weren't using this, patients weren't mixing it properly and invariably injecting it directly, and therefore only the shorter acting component or the goes, and the NPH component doesn't go sometimes well and doesn't have the desired effect. The intermediate acting component of the premixtures usually last for a period of 8 to 12 hours. They are not truly 24 hours acting ones, and therefore there is always a shoulder effect even if you are giving it twice a day, and therefore the shoulder effect, by the time that the effect of that insulin is ending, the last 2-3 hours usually are the time when the hyperglycemia used to occur. So evolution of premix insulin was a need at any given point of time. From biphasic human insulins, we shifted slowly to insulin analogs, which is again a mixture of shorter acting or a faster acting analog like aspart, and a protaminated form of aspart used to work or does work as a longer acting or an intermediate form. What has now come, or what we are talking today now more, is about a co-formulation, which is a first of its kind, a ready suspension, a ready mixture of aspart with the longest acting analog that we have available, that is degludec. So a 30% component of aspart and a 70% component of degludec mixes together as a co-formulation, and therefore becomes Rhizodec, or becomes this co-formulation insulin that we are talking about. Now the advantages, it is different of course from premixes. Premixes, again, as I told you, is a mixture of one biologically active solution and one insoluble, while the co-formulations mainly mixes two biologically active together in one. It mimics insulin secretion, physiologic secretion to the closest, because you have a 24 hours acting degludec component which is working as a basal insulin throughout the day, while the shorter acting component takes care of the postprandial peaks that usually happen when the patient eats the meals. There is no shoulder effect because there is a reduced variability. The longer acting component again works throughout the day, and the uniqueness is that you can still give this insulin twice a day, and therefore the desired 24-hour effect will still remain and becomes a much more simpler regimen for a patient to follow. Some data which is there with Rhizodec, as we talk about, this is a study done on around 1,000 patients. It is a study done in India by Dr. Jyoti Dev and his group. It looked at basically patients who were taking this insulin for a period of 1 year, and they were followed up for a period of 1 year, and they looked at their HbA1c change, and they mainly looked at the drop in HbA1c overall. Rhizodec showed an effective reduction of HbA1c by almost 1.7 to 1.8%, even in patients who were insulin naive or starting insulin for the first time, and also in patients who are already on oral drugs for a longer period of time. The efficacy in terms of fasting blood glucose reduction showed almost around 50 milligrams per deciliter of drop in fasting sugar. A postprandial reduction of almost around 82 milligrams per deciliter was seen in the study, mainly both for post-breakfast as well as post-lunch. The main important aspect again it looked at was the safety, and looked at the incidences of hypoglycemia in the study. Prior to when the patient started on Rhizodec, prior to that there were around 176 episodes of hypoglycemia, which over a period of 2, 3, 6 and 12 months came down to 28, 17 and 11. Considerable reduction, and when they looked at severe hypoglycemia, there were 0 cases over a period of 1 year following when the patients were put on this. So the next question goes to Dr. Shalini again. Shalini, what do you say about the patient-related aspects of Rhizodec regarding the convenience, quality of life and flexibility?
Of course. So when you have any new thing coming, it will be successful only if it is actually showing you real-world evidence of benefit. So for people to really benefit, you assess by certain things, looking at whether it is improving actually the quality of life The reason that we said all the challenges that were there with conventional and older premixes, were they met? Well, this is a real world data from Mumbai, Dr. Koval Center, which actually talks about assessment of quality of life in patients using Rhizodec co-formulation. So 89.8% patients reported improved quality of life in terms of less number of pricks that they had to take. 87% almost found it comfortable to inject Rhizodec in different social situations, and almost 94.2% patients could actually manage their day-to-day activities better on initiation with Rhizodec. So when you look at the total diabetes therapy-related quality of life score at the end of this study, from baseline you see an improvement in the quality of life to almost 70% from 67, and switching to Rhizodec was associated with an overall improvement in the quality of life and acceptance of this insulin as a flexible and efficacious insulin. Now, the benefit with this, you know, when you have a patient using a premix insulin, usually on a BD regime, the patient has to take 2 doses 12 hours apart. So, you know, even if he's not having a heavy breakfast, probably his lunch is heavier, but you cannot ask him to take a premix shot with lunch and then with dinner, which would probably be the second heavier meal. But with Rhizodec, this co-formulation, the best benefit is to give the shot with the biggest meal of the day. So if you have a patient who says that I come back home late in the night and that is my biggest meal, I have a light breakfast and I leave for work, and then I just carry some fruit or a small snack for lunch, and then I come home and I have a huge meal, so he can time his insulin with his dinner, just before his dinner. Similarly, somebody who just has a heavy breakfast and then the whole day he's busy at work and not really having huge meals, so he can take it in the morning. So it can be administered with the biggest meal, the major meal of the day. So the insulin gives him a meal time and meal related flexibility. Somebody who's just on a 1 shot of Rhizodec, you know, or even if he's on 2 shots of Rhizodec, the 2 shots can be taken. So suppose if breakfast and lunch are the 2 meals and he skips dinner or has a light dinner, he can take those 2 shots, the BD dose, at breakfast and lunch. Similarly, if his breakfast and dinner are the 2 meals, so the idea is whichever is the biggest meal, the first shot can be given at that time, and which is the second meal, there also he can take the second shot. Especially very, very useful for people who are traveling across time zones, corporate people, shift workers, you know. So 3 days in a week, you have a morning shift, 3 days in a week, you're doing an afternoon shift, and then you're doing a night shift. So you can keep rotating your insulin based on the biggest meal of the day. And especially patients, elderly patients who are dependent on maybe a compounder or a family member who's coming and giving the insulin shot to them. So then they can time it with that particular meal at the convenience of the healthcare provider on whom they depend for taking that shot. The ideal initiating dose for Rhizodec, somebody who's starting with 1 daily dose, is to start with maybe 10 units with the most carb heavy meal of the day and then up titrate the doses, and we'll come to that in a little while. Another important part is any co-formulation or any new insulin. How does it fare with the special populations? Is it safe for the elderly? Is it safe for CKD patients? Is it safe for hepatic patients? Of course, here's the data. Can be safely given to patients with type 2 diabetes with hepatic impairment, even during religious fast. So somebody who's going to have a heavy meal and then he's not going to eat the entire day, still it can be taken with that meal. Or when you break your fast in the night and you're going to have a heavy dinner, you can take it at that time. Even in adult patients with type 1 diabetes or elderly individuals with type 2 diabetes, which is again a very special group because you don't want your elderly people to have hypoglycemias. So there also it has a lot of convenience and approval. And of course, patients with both, like I said, renal impairment and hepatic impairment, it is found safe. So with this, let me ask sir, on moving on to basal insulins now. So we've discussed the challenges with conventional. We've talked about the co-formulation Rhizodec and its benefits, and now we move on to the analog newer generation basal insulins. How do the newer generation basal insulins address the unmet needs existing with the conventional insulins?
Yes, so Shalini very nicely highlighted the benefits of Rhizodec vis-a-vis Novimix or other premix insulin like Mixtard. And some of the benefits are also incorporated in this insulin because it contains about 70% of Degludec. Now, the major question related to basal insulin which were available and which are still available like Largin or Detamir or NPH, whether they really have the merits to be called basal insulin there are lots of questions. One, they are really not working for 24 hours. As we know, there is lots of variability, and there is intraday variability, interday variability, and they are not really basal. They are having some rapid action. So there were lots of unmet needs in this insulin, and fortunately we had now this Tresiba or Dagludec, which is far ahead or far distinct from the other basal insulin like NPH or Glargine. Of course, we can't undermine their importance because they worked for 30, 40, 50 years and gave lots of dividends and benefits to hundreds or millions of patients. But they had some limitation, as we can see through their pharmacokinetics. NPH onset of action was delayed, and it was lasting only for 12 hours, and also it was not universal. In some patients it would last even up to 24 hours. Glargine, again, it was not a peakless insulin. There were peaks around 8 to 12 hours, and again it was not lasting till 24 hours in some of the patients. Now this newer insulin, Dagludec or Tresiba, it starts very quick, almost no peak, and it lasts for almost 2 days and without any peak or troughs. So this is a real basal insulin, and this is also translated into its impact. So Tresiba has been compared for within day glycemic variability against Glargine. As you can very clearly see that almost entire day, 24 hours, there was hardly any change, major change, 23 to 28. Whereas if you see Glargine or Lantus, huge variation. You start, there is a huge insulin, almost the area under curve is 31%, and then it becomes almost half at the end of the day or 18 to 24 hours. So this is not truly basal insulin, as it can be seen very clearly from this graph. There is a huge within day glycemic variability. And then interday variability is even more. So if we use Tresiba versus Glargine, as you can see, Tresiba is consistently same all throughout the days, all different time zones, different days it is same. Whereas there is huge variation if we compare Glargine in different days. So both intraday and interday variation is very, very less with Tresiba against Glargine. So we could, with this quality, it is going to work better. So in terms of efficacy and safety of Tresiba, what are the clinical data points available today? Can you highlight them?
Yes. So there are some important studies which have been done with Tresiba, few of them which is what we are going to show you. So this is again a data done by Dr. Jyoti Dev and his team. Similarly, around 1,100 patients were here. They were followed up for a period of 1 year. It's a prospective non-interventional safety study. It mainly primary endpoint was to look at the safety of Degludec, to look at the hypoglycemia events, and to look at the change in HbA1c. From baseline A1C of 9.6 patients, the A1C at the end of 12 months came down by around 1.8. The fasting blood sugar came down by around 64. Significant reduction in fasting as well as HbA1c was seen at the end of the 1 year data, with no major side effects, and hypoglycemia, nocturnal hypoglycemia particularly, was much lesser as compared to the previous therapy. Switch Pro was another study. Now there were three, prior to Switch Pro, there were two studies done called Switch 1 and Switch 2. Switch 1 was done in patients with type 1 diabetes with Degludec, and Switch 2 was done in patients with type 2 diabetes with Degludec, looking at similar change in HbA1c and to look at mainly hypoglycemia events. Switch Pro was a follow-up to these studies where they looked at comparing Tresiba versus Glargine U100. Patients were, it was a study where patients were put on 16 weeks of Tresiba followed by 16 weeks of Glargine, and on vice versa. And patients were given put on the CGM monitoring, and mainly it looked at the time in range. It looked at the amount of time patients spent in the good time in time in range, and also at looking at time below range. So superiority of Tresiba was seen here over Glargine 100 U100 when they looked at the time in range profile. Mean time in range was around 72.11% for Tresiba versus 70.68, Statistically, they considered it to be significant, and estimated difference was around 1.43 or 20.6 minutes per day in favor of Tresiba over glargine 100. There are various other studies which shows these evidences. Begin is a phase 3A study. Switch 2, as I told you about, CVOT study called DeVote, which is done with degludec mainly, the only study mainly done for CV safety with this basal analog, and another real world evidence study called the UTreat2 type 2 diabetic study. And more or less, if you see here, the major advantage that Tresiba gives is mainly in terms of reduction of hypoglycemia. Nocturnal hypoglycemia reduced by somewhere almost from 49% to 55%, and severe hypoglycemia also came down in begin by almost 86% and almost 92% in the real world evidence data. So clearly showing this. Mainly the flexibility, as Dr. Tiven has already spoken about, that Tresiba gives is because of its longer half-life, can be injected at any time of the day and more or less would still give the same kind of effect, and the patient, that flexibility is there for patient to take irrespective of his timing. Safe to use around in wide populations, approved in pregnancy with grade A evidence, can be used in elderly population, renal and hepatic impairment, in pediatric age group as well, and in hospitalized patient and patients in adult patients mainly. Can easy to use, mainly faster onset and longer duration of action, longer lower within day-to-day variability is what it clearly gives us the picture, greater in terms of efficacy, safe because enough data to show in all kind of populations, and again wider dose time flexibility is what differentiates degludec or Tresiba from other basal insulins. So given the limitations of this conventional prandial insulins, we now move on to prandial ones quickly. How does ultra rapid acting insulin analogs have revolutionized the change of therapy?
Okay, so when we talked about the evolvement of the bolus insulins or the pre-meal insulins, of course, we had the ectrapids or the conventionals, which used to take about 30 to 60 minutes to come on board, and they would be there for about 6 to 8 hours, and there would be a tapering effect. Then came the analogs, the S-part insulin, which we said comes in fast. So 10 to 15 minutes, it's coming in, it's working for about an hour, 60 to 90 minutes, and then it's off in about 6 to 8 hours. Now, what is happening is now we have the 5-ASP, which is the fast-acting S-part, the ultra-fast-acting new generation bolus insulin. So like I said, conventional insulins had all these challenges. Now we have a ultra-fast insulin, which is as good as the physiologic bolus insulin that the body is producing. So just as you eat food and the signal goes, immediately you will see a surge in insulin that comes in. The ultra-rapid acting insulin does exactly that. Approaches even closer to physiology than all the other bolus insulins that we have been using, as you can see here. So clearly the area under curve is very, very much better, 74% greater when it comes to the postprandial glycemic surge that needs to be met when a patient eats his food. So FIASP actually showed 74% greater early glucose lowering effect compared to even S-part, which in turn showed 38% more glucose lowering effect than the regular human insulins that we had been using. And the best benefit, of course, hypoglycemia, which is such a feared complication for any patient who is on insulin. So within 4 hours after a meal, 22% less hypoglycemias. Between 2 to 4 hours after a meal, again 28% less hypoglycemias, and between 3 to 4 hours after a meal, again 30% less hypoglycemias. So definitely all across the spectrum, you see a significantly lower rate of delayed hypoglycemia. And like I said, convenience, mealtime dosing, very, very important. So it gives the patient the flexibility of taking it just 2 minutes before the meal or at the start of meal and up to 20 minutes after the meal as well. So very, very convenient when it comes to taking it in daily life, allowing for a more precise calculation of dose based on carbohydrates consumed, reduces the risk of hypoglycemia in case a meal is delayed, and is of course useful for patients who have irregular eating patterns. So when you compare it to the regular conventional human insulin that we were using as a bolus insulin, which like I said had a slower onset of action and a longer duration of action, here you have an ultra fast acting analog which works much faster and has a more physiological duration of action. It has a greater early glucose lowering effect like I showed you in that graph, and of course less risk of delayed hypoglycemia in comparison to a regular human insulin. And like I said, beautiful mealtime flexibility can be given 2 minutes before to up to 20 minutes after starting the meal, mimicking the physiological insulin secretion. So again, approval across the spectrum, across the wide range of populations, right from elderly people to pregnant females, to pediatric age group, to renal and hepatic impaired segment, to all the adults with diabetes, and can also be used in insulin pumps, and can be given both subcutaneously as well as intravenously as well. With this, I go to the question to Dr. Marwasa. What are the clinical merits of upgrading from a conventional to a new generation insulins, and why should we upgrade? Very, very important.
Yes, since we are running short of time, so I would just conclude that already all the benefits are highlighted by Salini and Tejas about basal insulin and bolus insulin and co-formulations. So I'm pretty sure that all are convinced that these insulins are extremely useful for a better control of A1C, to reach our target. At the same time, they produce lesser amount of hypoglycemia, and particularly severe hypoglycemia and nocturnal hypoglycemia. Because whenever you touch a target, you should not overstep. This is the problem, that you can give a lower target, you will not overstep it. But you try to achieve the target, it's likely that you are going to overstep. But with this newer insulin, you are less likely to overstep, and hence lesser chances of hypoglycemia. Lesser glycemic variability, because very less intraday and intraday variation with basal insulin, and there is a wide window of flexibility which gives lots of convenience to the patients, and we are having newer devices which can help our patients. So these insulins are smart, and they are having lots of qualities which can be enormously useful to all our patients. Now, shifting is not difficult, and I think because of the convenience of time and restrictions, we would like to just conclude, and I would request Salini to give us her final comments.
So as we're running short of time, I'll just quickly talk to you about how do you upgrade your patient to co-formulation from a premix. So like I said, if your patient is on 1 dose of premix, you just need to do a 1:1 dose that is split over the main meal. So you can give Rhizodeg 1 shot with the biggest meal of the day. If your patient is on 2 doses of a premix, so again it has to be a 1:1 split, and you can give it with 2 meals, whichever are the 2 biggest meals here. Somebody who is on a premix 3 times, patients who don't want a basal bolus, we sometimes give them a premix 3 times. So for those patients also, it has been shown that Rhizodeg given twice is as good as a premix given thrice before all 3 meals. So that's how you do a dose split between these patients. And of course, for patients who are getting a hypoglycemia with the premix insulin, or where an HbA1c is already less than 8%, there a dose reduction from the premix total dose, you need to do a 10 to 20% dose reduction when you switch them to these analog designer insulins, because they are, like I said, they're faster, they're more predictable, they give less hypoglycemias, then they're more efficacious. So how do you upgrade to Tresiba? Somebody who's on a single dose of a basal insulin, if he's on a glargine insulin or something, you just do a 1:1 switch to Tresiba once a day. Or if your patient is taking 2 doses of basal insulin twice a day, patients who need high amount of basal insulin, you will have patients who are on glargine 2 doses in a day. There you do a 20% dose reduction from the total insulin requirement that the patient has, and you do a 1:1 switch by giving him Tresiba once a day. With that, we'll end this seminar, this symposium. Thank you so much.